I will be discussing on medical therapy and endocarditis prophylaxis in rheumatic valve disease. I have no declaration to make. Nepal, as most of us know, is a small country situated in Asia. It is between the China and Indian subcontinent. It's relatively a beautiful country, and I request you all to visit this country whenever you have time. Now, going to the historic perspective of rheumatic heart disease, in the 1920s to 1960s, the incidence of rheumatic heart disease was quite high. It was one of the leading causes of cardiac problems throughout the world. The incidence was almost 20 to 50 per 100,000 cases. However, in the present era, the incidence has decreased, especially in the affluent countries. It has decreased to almost less than 1 per 100,000 at present. However, the present prevalence and incidence is still high in developing world. The highest reported is the prevalence of 30 per 1,000 school children. The clinical manifestation was initially described in 1685 by Thomas Sydenham, and the febrile illness was connected to polyarthritis with rheumatic fever in 1839. The Jones criteria was established in 1944, thereby followed by the famous saying of rheumatic fever licks the joints and bites the heart in 1984. Now, if you look at the prevalence of rheumatic heart disease from 1990 to 2015, we see that in certain part of the world, especially the affluent countries, it has drastically decreased. And whereas although the prevalence is on the fall, it has not decreased significantly in many of the countries. Similar is the pattern of rheumatic heart disease and mortality. If you look at the endemic and non-endemic pattern based on the classification of endemicity, saying that if a country or a region has more than 0.15 deaths per 100,000 population, it was mentioned as endemic area. Most of the areas have low prevalence, but high prevalence is still seen in South Asia, Pacific Islands, and the African subcontinent. The present scenario of the disease is that it has been almost eradicated from the developing world. However, the global burden of the disease is still high. It is 33.4 million cases worldwide. This has been mentioned in the recent NEJM article by David A. Watkins. The good thing about the disappearance of rheumatic heart disease is that we are getting rid of one of the cardiac problems. However, the problem is that the near disappearance in developing nations has led to a relative neglect of the disease in the recent years. This will be depicted by the data that I show here. The amount of funding that is there for death and research development in rheumatic fever and rheumatic heart disease is relatively low as compared to other diseases. As we all know, the reduction in rheumatic heart disease is attributed to improvement in socio-economic conditions, availability of healthcare facility, and widespread use of penicillin or antibiotics to treat streptococcal sore throat. Now, when discussing about medical therapy of rheumatic heart disease, I'd like to discuss in the following three headings: the prevention of rheumatic fever as such, management of acute rheumatic fever, which will involve elimination of the group beta hemolytic group A streptococcus, suppression of inflammation or the autoimmune response, and suppression and the supportive treatment for congestive heart failure in rheumatic fever. The third topic would be preventing recurrence of rheumatic fever. Prevention of rheumatic fever is basically based on elimination of group A beta hemolytic streptococcus from the pharynx. The drug of choice would be the oral penicillin V. Other oral drugs like ampicillin and amoxicillin are equally effective. If oral methods are not dependable or desired, a single dose of intramuscular benzathine penicillin would suffice to eradicate group A beta hemolytic streptococcus from the pharynx. If a person is allergic to penicillin, erythromycin, clarithromycin, or azithromycin are equally good drugs. And the first generation cephalosporin are also good drugs. However, it is to be remembered that 15% of patients who are allergic to penicillin are also allergic to cephalosporins. We should be careful in not to use tetracyclines or sulfonamides for eradication of group A beta hemolytic streptococcus. In the initial period of rheumatic heart disease or rheumatic fever, for the first 24 hours of starting antibiotics, the child has to avoid going to school or avoid going to public places so that he does not cross-infect to other peers. What to do in patients who are or people who are only carriers of streptococcus and not diseased persons? Normally, antimicrobials are not required in these patients. However, in certain exceptions, these patients need to be treated. They should be treated during the outbreaks of rheumatic fever or post-streptococcal glomerulonephritis. If they have a family history of rheumatic fever, during outbreaks of group A beta hemolytic streptococcus pharyngitis in a small closed community, or when tonsillectomy is contemplated in these patients, or when there is group A beta hemolytic streptococcus toxic syndrome or necrotizing fasciitis in the household members. Now, the management of acute rheumatic fever as such. As I said, one of the most important things is to eliminate group A beta hemolytic streptococcus, and most of this has been talked in the previous slides. Second would be suppressing the inflammation or the autoimmune response, followed by supportive treatment for congestive cardiac failure. Antibiotics to eliminate group A beta hemolytic streptococcus. Now, how do we suppress the inflammation? Aspirin is the drug of choice to suppress the inflammation. Aspirin is such a reliable and wonder drug to suppress inflammation in acute rheumatic arthritis, is that if a patient does not respond to up to 24 or to 36 hours of initiating aspirin, the diagnosis has to be doubt, not the drug. So aspirin is very reliable to suppress the inflammation. The attempted blood level aspirin should be around 25 to 30 milligram percentage. The drugs should be given for 6 to 8 weeks, followed by gradual tapering of the drugs. Tapering has to start once the signs and symptoms of acute rheumatic fever has resolved and acute phase reactants are normalized. During discontinuation or withdrawal of the drug, close monitoring of acute phase reactants for rebound of rheumatic fever has also to be monitored. Some of these patients develop carditis, which is evident by new onset murmurs or changing murmurs, cardiomegaly, presence of a third heart sound, or presence of heart failure in these patients. In patients who develop carditis, it is advisable that we start them on prednisolone instead of salicylate therapy for 2 to 6 weeks, depending on the severity of the carditis and the response of acute phase reactants. And after that, prednisolone is gradually to be tapered. Initiating salicylates during the tapering phase of prednisolone is going to decrease the rebound phenomena in these patients. So we decrease the prednisolone and we initiate aspirin in these patients and then continue aspirin for next 2 to 4 weeks and then stop it, depending on the response of acute phase reactants. Some of these patients develop congestive cardiac failure. The standard treatment of congestive cardiac failure always stands true for these patients also. It is to be remembered that if a person does not respond to steroids, does not respond to medical treatment of congestive cardiac failure, he or she may be a candidate for surgical intervention. Although surgical intervention in these patients at the time of surgery in acute phase would be risky, but this may be the only method of saving life in some of these patients. Finally, going for prevention of recurrence of rheumatic fever. What is the aim of prevention of preventing rheumatic fever for? It is said that a person who has got good beta hemolytic streptococcus pharyngitis, only 3% of patients who have pharyngitis of this bacteria develop acute rheumatic fever. But a person who has had rheumatic fever in the past and he has a recurrence of group A beta hemolytic streptococcus infection, the chance of developing rheumatic fever is significantly high in these patients. That is why the aim of the treatment is to make sure that the patient do not develop streptococcus from pharyngitis again. And if they develop pharyngitis again, they may develop rheumatic fever and they may develop further damage of the heart valves. So this is the aim of the therapy. Now, the duration of prophylaxis has been clear-cut these days. If a patient has no carditis, only rheumatic fever, the treatment should be given for 5 years or up to the age of 21, whichever is longer. If a patient has carditis without residual valve disease, it is to be given for 10 years or well into adulthood, that is again 21 to 24 years, whichever is longer. And if a patient has got carditis and valve involvement, it is to be given for 10 years or up to the age of 40, whichever is longer. Most of us give it for until the age of 40. Some advocate that the penicillin prophylaxis has to be there for lifelong, but most of us now these days practice only till the age of 40 years. Now, which antibiotic is to be used? The most effective, possibly the most easiest antibiotic would be a benzathine penicillin in these patients. 1.2 million units above the age of 30 and half the dose below the weight of 30 kgs. Oral penicillin B is a tedious drug along with sulfonamides and erythromycins because these drugs have to be taken twice a day and for significantly a long time, possibly 5 years, 10 years, or up to the age of 40, whichever is longer. So the most effective has been the intramuscular injection of benzathine penicillin in these patients. A word about penicillin injections. Most of us prescribe the drug and forget how it is given. Few factors have to be taken into account. There are certain factors which affect the bioavailability of penicillin. The injection should be given deep into the muscle. If a superficial injection is given, it remains subcutaneously, its absorption is not as desired, and the serum levels are not as adequate. This may result in a recurrence of the disease. The whole content of the penicillin vial has to be emptied into the syringe, and the injection has to be given deep intramuscular. If we fail to do that, the amount of drug that is required may not be delivered to the patient. Now, one of the problems of benzathine penicillin is the painful nature of the injection. One of the ways to decrease the pain is to slightly warm the vial and make sure it is at around 37 degrees so that the injection becomes less painful. Coming to endocarditis prophylaxis, the infective endocarditis, the yearly incidence is relatively high, almost up to 10 per 100,000 cases. And the mortality is very important. It's very high. We have also seen that the mortality in these patients is anywhere from 15 to 30% of these patients do not survive, even in the hospital. Links between infective endocarditis and invasive procedures was first described in 1920, and the role of antibiotic prophylaxis was first recommended by American Heart Association in 1955. There are other non-specific preventive measures to be taken in patients with who are at risk of infective endocarditis, like maintaining a good hygiene of the oral mucosa, skin, and so on. there has been certain restriction in antibiotic prophylaxis in the recent years. The European and the American guidelines are now together in saying that this is to be given only to patients perceived to be at highest risk of infective endocarditis. This has been done looking at the background of weak evidence of antibiotic prophylaxis in these patients. The risk of anaphylaxis is equally high in these patients, and the risk of antibiotic resistance. So at this moment of time, only those patients who are at high risk of infective endocarditis or those patients who are undergoing high risk procedures should be given infective endocarditis prophylaxis. Now, what is a high risk procedure? As evident by the American guidelines, the European guidelines, and the NICE guidelines from the United Kingdom, those patients who have got a prosthetic valve or a prosthetic material in the heart are at high risk. Of a patient who has got a high infective endocarditis before, or a patient with cyanotic congenital heart disease, or repaired congenital heart disease with a prosthetic material for the past 6 months, they are at high risk of infective endocarditis. Those patients with post-cardiac transplant and valvulopathy are also at high risk. The NICE guidelines also mention hypertrophic cardiomyopathy as one of the high risk for infective endocarditis. They are also intermediate and low risk, and most of the times we only recommend IE prophylaxis for high risk procedures. Now, one of the things to be remembered is that mitral valve prolapse and hypertrophic cardiomyopathy have not been taken as high risk procedure in the American and the European guidelines. The mitral valve prolapse and bicuspid aortic valve have a relatively high incidence of bacterial endocarditis. Now, what are the high risk procedures? Most of the dental procedures are high risk procedures, like manipulation of the dental tissue, periapical region manipulation, or any procedure that requires perforation of oral gingiva is also a high risk procedure. Procedures that are performed on the respiratory tract, like the or infected skin, are also high risk procedures. Now, what is the antibiotic prophylaxis to be given? I think it's quite simple. Giving amoxicillin or ampicillin 2 grams IV almost 20 to 30 to 60 minutes before the procedure, or clindamycin for 600 milligrams IV can be given in these patients. Now, there has been a recent article about bicuspid aortic valve and mitral valve prolapse. Remember, bicuspid aortic valve and mitral valve prolapse have not been considered as high risk situations as far as infective endocarditis is there. So there has been a recent study in JAC from Spain. They have included almost 3,000 patients who have infective endocarditis and bicuspid aortic valve and mitral valve prolapse. The results of this is as follows. They have seen that those patients with bicuspid aortic valve and mitral valve prolapse have high incidence of virulent streptococci in their culture, as compared to patients with low or moderate risk valve disease. Again, they have got more associated odontological procedures. Cardiac complications are high in patients with bicuspid aortic valve and mitral valve prolapse and patients who have got cardiac surgery. And the cardiac surgery incidence is also high in patients who have got mitral valve prolapse and bicuspid aortic valve. So this study says that bicuspid aortic valve and mitral valve prolapse should also be considered as a high risk situation as far as infective endocarditis is concerned. Finally, I would like to conclude by saying that rheumatic fever is totally an eradicable disease. It has been proved by the fact that it has been almost eradicated in some of the countries and still at a high incidence in many of the countries. Those countries, as I gather, who had high incidence of rheumatic fever in the past, in those countries also, as in our country also, the incidence is significantly decreasing. So it's a totally an eradicable disease. It has a good prognosis looking at the modern medical technology. Those patients who have got chronic valvular heart disease are also treatable by various methods. My following speakers will be discussing about it. And IE prophylaxis, when used appropriately, is very useful in these patients. Thank you.
Thank you very much. This paper is open for questions.
Dr. Hassan Najjar from Iraq. When you talk about mitral valve prolapse, I think you need to specify that those mitral valve prolapse associated with significant degree of mitral regurgitation, because mitral valve prolapse, the valve could be prolapsing, but it's not regurgitant. Then there will be no chance of having endocarditis.
Yes. Yes.
That's what I meant.
Yeah, thank you.
Thank you. I'm from Ethiopia. My question is to give Byzantine penicillin injection with local lidocaine. What's your experience? We are giving that for the pain they are complaining.
I have heard of this, but I've never had any experience about giving local anesthesia and penicillin injection together. If you have any experience, maybe you can share it. I have no experience.
The problem is working or not, but they have to decrease the pain, so they are adherent for the medication.
Thank you, Nigel Wilson, New Zealand. Thank you for a nice talk. Just on your last slide, I still wasn't quite sure that in your literature search for the talk, did you come across pre-operative rheumatic heart disease patients and their relative risk of endocarditis compared with the background population?
Sorry, I didn't get your question.
Well, I mean, we all know that post-operatively prosthetic valves, operated valves are at high risk. We know that there's some subsets of mitral valve prolapse, but did you find, is there any data in the literature about infective endocarditis in people who've just got isolated mitral regurgitation, just got aortic regurgitation, that are rheumatic as opposed to other valve etiologies?
Yeah, I got this literature from Jack, that study from Spain. They have shown that these patients had a higher incidence of variants in their blood group, and they had higher incidence of complication as compared to which is even higher than the high risk group.
Yes,
so they wanted to advise that.
But they weren't rheumatic patients, though, were they?
They were bicuspid aortic valve and mitral valve prolapse with mitral regurgitation.
Yes.
So they wanted to include this also into the infective endocarditis prophylaxis, but they are not rheumatic.
Yeah, that's right.
Yeah.
I would like to ask you a practical question because I don't have experience in rheumatic fever. You said about preventing prevention, we give aspirin. I would like to know the dose of aspirin because we use for prophylaxis of coronary heart disease very low dose. Would you like to say the dose?
Yeah, the normal dose would be 100 milligram per kilogram body weight. The maximum
100 milligram per kilogram.
Milligram. The maximum dose would be 8 grams per day, divided into 3 to 4 divided.
Right. What about is any experience, since you review the literature, about quinolones for the treatment of endocarditis or prophylaxis? Quinolones.
No, I'm not aware of that.
I'm not also.
Thank you very much.